Welcome to Your Doctor Wants to Quit, a podcast inspired by the need to save healthcare in America. I am Dr. Joy, a board-certified emergency physician, and I created this podcast to shed light on the challenges our healthcare system is facing through the multiple lenses of doctors, other healthcare professionals, and patients. By listening and working together, I believe we can fix healthcare in America for all of us.
We didn't have to do all of this before. We didn't have to have 18 bullet points and all of these little things that are audited, for compliance because some regulatory agency says we have to check this box or do that thing in order to get paid this amount of money. And that's changed. And unfortunately, that's just something that, one person, one physician, one solo practice doctor cannot stop. It's like trying to stop a locomotive. By standing in front of it, you can't do it. You'll get run over.
You are listening to the voice of Dr. Damian Roche, a board-certified cardiologist who prioritizes health education, risk factor modification, and disease prevention, which involves a deep commitment to collaborative partnership with his patients.
My name is Dr. Damian Roche. I'm an invasive cardiologist, and I'm in private practice here in San Diego, California. I work for a 10-man cardiology group. We actually have two offices. One is in La Jolla and the other is actually in Encinitas. Both of those are cities here in San Diego County. I actually grew up in the Midwest. I grew up in Northwest Ohio, in a beautiful Midwest town called Toledo, Ohio, full of osteopathic physicians, of which I happen to be one. I went to medical school in Sarasota, Florida. And after that, I returned back to Ohio for the last 2 years of medical school. I did my third and fourth year of medical school, mostly at the Cleveland Clinic in Northeast Ohio. And from there, I went on to Chicago, another great Midwest city, to do my training in cardiology. And at the conclusion of that training, I got a job offer, very fortunately, to move out here to sunny San Diego. And I've been here ever since. This is my 10th year in practice, and I remain very happily in private practice for now, despite the challenges that we're starting to face now in medicine. And grateful to be here on this podcast today talking about a very important topic that I think is really on the minds of most physicians in this day and age.
Can you remember the first time that you thought you might want to be a doctor? How did that thought come about? What inspired it? And how did it evolve over time?
When I was a young kid, I had a wonderful pediatrician. He was an incredibly kind man and that would take care of all of his patients until they were 18 years old. And if you stuck around, most of us would even come back and see him when we were college students, when we would go into his office. And I especially appreciated this when I was in my 20s and still going to see my pediatrician. You could just tell that he was so passionate about taking care of his patients. And there was just this deep connection. I'd known this guy for 22 years. I mean, he literally saw me within hours after I was born. And he always had a warm smile on his face, and he was always trying really hard to make sure that whatever was worrying me would not be a worry by the time I walked out of the office. He was a real inspiration. I think that was one of the first and earliest times in my life that I realized what an awesome career choice being a doctor was, and that really stuck with me throughout college. And I had a fairly open mind in college about what other opportunities I might want to pursue, but that was always kind of sort of first and foremost on my mind, is to try to be sort of a guide and a healer for people like he was for me. Unfortunately, he passed away a few years ago. It was a big loss for our community back in Northwest Ohio, but he was just an inspiring person.
Was he also in private practice as you are now?
He was in private practice. He was actually in solo private practice. He had a small office with about 3 exam rooms, and his wife was an RN, and she was also basically his medical assistant and nurse and office manager. She handled everything. They were essentially a two-person operation.
So really kind of an old school model, kind of the Norman Rockwell portrait of a physician. Would you say that?
Couldn't have said it better.
Good description.
Literally a Norman Rockwell painting. You see that classic one of the kid sitting on the doctor's exam table. It's exactly what comes to mind when I think of him. Unfortunately, he passed away before I was able to share in my joy of graduating medical school with him. But he was someone who actually mentored and encouraged that vocation, that calling to medicine in his patients.
So it sounds like your inspiration to become a doctor really came from your pediatrician. Did you have anyone else in the family that was in the career of medicine to talk to or discuss your choices with?
Well, I certainly had people that encouraged it. My mother and my father both were very encouraging of my goal and my desire to become a doctor. But as far as I know, am the first physician in my family. There has never really been a lot of science-oriented people on really either side of my family. A lot more, I think, mechanical and industrial. Toledo's kind of, it's called the glass city. And so my father worked for a company that made auto glass. My mom actually worked for a hospital. She worked in healthcare, but she actually worked in hospital administration. So there was a little exposure to healthcare on that side of my family, but no physicians. So I was the first one to try and navigate my way through the system of applying to and getting in, and then more importantly, surviving and getting through medical school and residency training afterwards. So being the first one in your family to go through it is definitely, I think, challenging. I wouldn't recommend it. It's always better to have a mentor or someone that can kind of show you some shortcuts and give you some tips, but it's definitely doable for anybody that wants to do it, and I'm certainly glad I did.
It sounds like you would also encourage young people to pursue a career in medicine even to this day. Is that accurate?
I think it's accurate to say that I still believe that medicine is a noble profession. I think it is a pursuit that is worth pursuing. But more than ever, there are pitfalls that have not always been there. And those pitfalls are increasing in number and in size and in magnitude. And unfortunately, for some people, and I think this is where this podcast is very interesting on this topic of why your doctor wants to quit. Some people start down the path and you reach a sort of point of no return. And that can be a challenge. If you borrow a lot of money to go to medical school, they don't forgive that debt if you suddenly realize that you've made the wrong career choice. They don't allow you to just not pay your bills, not pay your loans. They will come for that debt. Whether or not you've managed to graduate and become a successful physician or not. And I think that compounds what's already a stressful situation for many people. There's a lot of hard work, demands placed on medical students and medical residents. And so I think I certainly would recommend for the right person that has really discerned their vocation and discerned their calling, that they certainly consider medicine, but not without doing a little bit more research now and looking into what you're really getting yourself into. And that may involve shadowing doctors, talking to other medical students or residents, getting exposure to the field, perhaps working as a medical assistant is a great way to become more aware of what the day-to-day life of a physician looks like in this day and age. But I haven't given up on our profession yet. But there's definitely room for improvement as well on our part.
If you had to do it over again, would you make the same choice?
I think I would. I think I would make the same choice. I don't regret doing it. I certainly don't regret doing it. I don't regret putting in the time and doing the work to get to where I have now. But as I said before, I think it's not everything that I thought it would be. Things are not quite what you expect them to be as you find yourself standing on the other side of the fence. And that's definitely something that we think about and struggle with every day in medicine. There's this vision of what we imagine ourselves to be in that distant future. And you have to think about being a first-year medical student and doing something like cardiology, where you have 4 years of medical school. an internship, and then 2 years of residency training, and then 3 to 4 years of cardiology training. After that, you're looking at, over a decade of training just to get to that other side when you're actually, for the very first time, putting on that white coat and seeing your very first patient. Over a decade will have transpired from your first day in that seat in medical school. And a lot changes over a decade in science and in medicine and in the world. And much has changed since I was a first-year student in medical school. We've had a global pandemic. We've had a lot of world events that have changed medicine, some for better and some for worse. And that change is definitely, I think, part of what makes being a physician a challenge, because you have this vision of where you think you're going to be, and it's not always quite where you wind up.
You took a little bit of a different path to go through medical training as a DO, and not everyone that's listening might really even know what that is or what that's about. So maybe you could give us a little bit of information about how DO differs from MD in terms of the training, the curriculum, philosophy, etc.
Absolutely. So I'm very proud to be an osteopathic physician. There's a very large sort of Midwest tradition of osteopathy. It dates back to around the time of the Civil War. There was an MD, a physician by the name of Andrew Taylor Still, who by all accounts was an excellent physician and surgeon at that time, who took some issue with some of the debatable, perhaps objectionable medical practices of that time, excessive amputations, non-evidence-based applications of some therapies, and ultimately had a bit of a different philosophy that the human body has a tendency to want to heal itself. And ultimately, after some conflicts with other folks in his previous profession of being an MD, decided to open his own medical school. And that medical school emphasized this sort of integrative approach of all of the organ systems of the body sort of functioning together as a unit, and the body kind of having a natural tendency of wanting to heal itself, and the role of a physician being defined as sort of a guide and a healer aimed at helping the body achieve that sort of natural state. And that type of philosophy makes a lot of sense to me. There's a lot of misperceptions, I think, about osteopathic medicine in the public, that it's some sort of alternative medical practice, or that it's perhaps more aligned with like chiropractic care. It really has nothing to do with any of that. It really is just simply a different philosophical application of the same exact science that the MDs use. There is a slightly more emphasized approach to manual or musculoskeletal medicine, physical diagnosis, examining patients in a very hands-on kind of way, and sometimes doing osteopathic manipulative therapies. But generally in 2025, we have a very similar curriculum, nearly identical in most cases. And now everything has sort of merged under the umbrella of the AAMC, which is the accrediting organization in this country that accredits medical schools. And now under the ACGME, which is the organization that largely regulates postgraduate training, or what physicians do after they graduate from medical school, working in hospitals for a period of time under supervision of more experienced physicians. So we're a wonderful group of doctors. Check us out if you've never seen an osteopathic physician. The last several presidents of the United States have actually chosen osteopathic physicians as their physician. But we're in the military, we're in NASA, we're all over the place as DOs, and we're a great group of doctors. And so if that approach is something that interests you, definitely go to the American Osteopathic Association website. You can find a DO near you and check us out.
It sounds like choosing that different path, DO versus MD, was a very intentional one for you. I think you and I are about the same generation and went through the process of medical training at around the same time, over a decade ago now. And I can recall when I was a student, undergraduate at first, and eventually in medical school as well, I remember a lot of times hearing from physicians that were maybe 10 to 15, coming up on 20 years into practice, feeling a little bit disillusioned with the profession. I wouldn't say necessarily outright discouraging my pursuit of a career as a doctor, but giving maybe a little bit of a warning of what was to come. Did you experience that at all? Because it sounds like you spoke very highly of this pediatrician who inspired you, and he seemed very positive, but were there others around you that had a more foreboding perspective on the future of a career in medicine?
I think the answer to that question is a clear yes. And I started my medical training in 2005 as a medical student. I graduated medical school in 2009. There was a very fundamental change that happened in between those 4 years, which was the passage and implementation of the Affordable Care Act, which was rolling out right around the time that I was starting my training as an intern. So at this point, I'd graduated from medical school, I'd had my medical degree, and now I'm essentially sort of a rookie doctor on the floors of the hospital, learning internal medicine skills. And when you do general internal medicine, you rotate with lots of different specialties. And that's a great thing because you get to see lots of different perspectives on lots of different kinds of medicine. You might rotate 1 month with a cardiologist. The next month, you might be doing inpatient general medical care. The next month, you might be rotating with a gastroenterologist or an endocrinologist just treating diabetes. And sometimes I would rotate with physicians who were extremely joyous. They were just consummate physicians who loved what they do. And you just got this sense that they were never going to retire, that they were probably going to die in that hospital with their stethoscope on, seeing patients because they loved it so much and they would never take their white coats off. And there were a few in that rotation already back then that kind of stood out a little differently from the happy ones. And you got this sense that exactly what you were referring to. They're a little frustrated, a little dissatisfied, a little unhappy with their present clinical situation, and that they were eager to wrap their career up or perhaps retire early or move on to something else. And that was an interesting contrast to see because while I could see that it was happening at that phase of my career, it wasn't entirely clear why. And as the years would go on, later I would eventually become subject to some of those forces myself, and that continues to this day. But not everybody was a happy camper back in 2009, that's for sure.
What are some of the things that you were most surprised about as you went through medical school and residency training and then ultimately fellowship?
It's such a unique experience from one minute to the next, and that's what definitely keeps us on our toes and makes the job interesting. Some patients, when you see them, they're very, very deferential to your recommendations. They want to do whatever you tell them to do. They put their ultimate trust in you, and whatever you tell them, there's no question they're going to do it. And other patients approach physicians with a lot of skepticism. A lot of doubt, perhaps even a little distrust. And that's not necessarily a bad thing because it means that they're invested in their own health and their own well-being. But it's a challenge because not everybody responds to you or your recommendations the same way. When you're going through school, you just assume it's very cut and dry. You learn what the pathology is, you learn what the medical therapy or the surgical treatment is for that condition, and then you recommend it to your patient and you accomplish that and you move on. But that's not really how it works. There's a lot of discussion. The real art of medicine, not the science, but the art of medicine transacts in this sort of gray space in between. It is very much not black and white. And I think that's what separates good doctors from bad ones. The good ones, I think, can really meet their patients in that space and negotiate a clinical outcome that's positive for the patient within that patient's preferences. And that's something that's not often talked about, certainly not in medical school when you're trying to just sort of drink water from a fire hose and learn all of this medicine that you need to learn to be safe. But that was, I think, one of the first things that struck me when I actually became a doctor in those early months and those early years is that you really never know what's on the other side of that door.
That's kind of what keeps it interesting and exciting, at least for me. Maybe that's my bent towards emergency medicine is I like the idea of not knowing what's going to walk through the door. Not everybody likes that, though.
Variety is the slice of life, as they say.
Yes, for sure. You described the challenge that you weren't expecting about the the people that would come to see you that would seek your advice may not always be in alignment or resonate with how you might explain things or the things that you might recommend, that's not really a skill set that was taught when you went through training.
My third and fourth year of medical school was at a Cleveland Clinic hospital, and that's also where I did my residency at the Cleveland Clinic Health System. And Cleveland is a very, very, very busy hospital system at Cleveland Clinic, and the volume of patients that we were seeing was very, very high, definitely on the higher end, I think, nationally. And again, you sort of learn on the job, right? The first month was a little tricky. You're very worried about even handing out a baby aspirin to somebody. And then, after you work some of the harder shifts, emergency room being one of them, by the way, which is probably the most challenging place I think I've ever worked in a hospital as a physician, you realize that you don't have 30 to 40 minutes with every single patient. You just don't have those resources. There aren't that many beds in the hospital. There isn't that many chairs in the waiting room. You have to move people along. And I think that really is part of the challenge as a trainee and as a learner. You want to make sure that you're helping patients and you're doing all the right things, but you have to be quick with your wits and the resources that you have. You can have a very meaningful clinical encounter with somebody in a matter of 2 or 3 minutes, but being able to connect with your patient is very important, and to be able to establish that rapport and trust, even if it's the first time you've met, even if it's the only time you're ever going to meet.
I wanted to get your perspective on your own experience on the other side of that invisible divide, because you shared with us a little bit about what it's like to be the physician in that doctor-patient relationship and to have to build rapport, to recognize that different people have different preferences, different value systems that guide the type of treatment program that they'd be interested in. I'm wondering if you could share a little bit about when you've been on the other side of that encounter as the patient and what you've noticed through your unique lens.
One of the hardest things I think you can do as a physician is be a patient yourself. I find it to be probably one of the most challenging aspects of being a doctor, because we have this burden of knowledge. We're taught to think about what all of the potential outcomes of a certain cascade or constellation of symptoms might be. And generally, at least in my area of work in cardiology, we're taught to prioritize the worst possible outcome first and focus on that and try to cross that off of our list of things that we're worried about. The problem is when you're a patient, you tend to default to that same tendency. You have a cough and you immediately wonder if you have lung cancer. You have a headache, you wonder if it might be a brain tumor. It's very, very challenging to suspend your knowledge base and make yourself vulnerable. Other physicians have spoken about this on other podcasts. I won't name any names, but a very famous one who's very common on the internet has spoken about the gift that a patient gives to their physician is that shared moment of being vulnerable. And I truly think that was one of the most beautiful ways it's ever been described, is being vulnerable and putting your trust in another human being with expertise to care for you and to try and help make you better. It's difficult being a patient. When I was 16 years old, I had a traumatic injury to my eye. I actually had a retina detach in multiple places, and it required multiple surgeries to stabilize my vision, and a rather intense period of several years of very, very frequent visits to a retinal vitreous ophthalmologist. A lot of pain, a lot of discomfort, a lot of recovery after surgery, and a lot of questions as to whether or not things would get better. And that perspective of being a patient was very different because I hadn't been a physician yet. I put all of my trust in this surgeon that had taken absolutely excellent care of me. Thank you, Dr. Cozy from Toledo, Ohio, if you're hearing this podcast today. But once I became a doctor, it's very, very different. All of those things that I mentioned come into play.
What do you think are the greatest ethical challenges that are faced by doctors today?
Healthcare isn't free. I think that's problem number one that we face. In an ideal world where nothing costs anything, everyone should be able to have every single test done that they need. They should be able to have the very best treatment money can buy, and that should afford them the very best outcome that they possibly can have. But the situation in our country today, and most countries in the world, is such that that is not feasible. We have limited resources, time being one and financial resources being another. And one of the real ethical challenges I think we face as doctors is trying to make sure that we are appropriate stewards of the resources that we have, that we're not disenfranchising patients from care that they deserve at the behest of other entities that might place constraints on us. For instance, insurance companies that might say, we don't want you to order this test. We don't want you to order the more expensive medication. And also being reasonable to say, you know what, we don't have to prescribe you a $500 medication when there's a $4 medication that absolutely unquestionably works just as well. That, I think, is a big ethical challenge for us, is to try to figure out how to strike that balance appropriately so that we're not over-prescribing, we're not over-testing, we're not using things that could be used elsewhere for patients that might need those resources more. But we're also not shortchanging anyone on the care that they really deserve.
Right now, I would say the gatekeepers for what tests get paid for, what type of care gets paid for, would be insurance companies, for the most part. And it sounds like what you're suggesting is that physicians would be better at serving in the role of stewards of those resources and making those decisions.
I absolutely 100% believe that physicians are the best stewards of those particular resources, but unfortunately that's not the case in this day and age. And that, I think, is probably one of the major reasons that we see some doctors running for the exits, because that's not how it used to be in this country, and it's definitely not how it should be. But unfortunately, for most folks in most places under present circumstances, that is how it is.
As a cardiologist, I'm assuming that you often are involved in doing peer-to-peer discussions, and I'm just curious if you can explain a little bit about what a peer-to-peer is and how often you have to do them and what the purpose of that is.
Absolutely. So a peer-to-peer discussion is one of the most dreaded things in all of medicine. It sounds like this very positive term, like it's just two doctors getting together in a room and having a nice scholarly conversation about care, right? It could not be farther from the truth. So what a peer-to-peer, as we say in the biz, is for the audience, is when a physician orders a test, typically a test that costs some money beyond a few dollars, and for whatever reason, perhaps it's automatically, perhaps it's semi-automatically, perhaps it's as the result of a review, that test is preliminarily, we will say, placed on hold, or a better word, I would say more practically, is denied. The insurance provider essentially says, we're not going to pay for this test. And now what happens is we're at an impasse. So let me give this story to you kind of through the lens of my day-to-day. So let's say I have a middle-aged man like me that comes into my office and says, Dr. Raj, I'm having chest pain. Every time I take a walk down the street, I feel a crushing pain in my chest, and I can feel that pain go into my arm and my neck and my jaw. Well, to a cardiologist, those are the classic symptoms of a blockage in a heart artery, which is the setup to a heart attack, which can be fatal. And so our antenna immediately goes up when we hear that complaint in a cardiologist office. And we're actually not that sophisticated, believe it or not, in cardiology. We actually have just a fairly small number of tests that we do. Some specialties have hundreds and hundreds of tests and imaging studies that we do, but we really only have maybe, I don't know, a dozen tests that we do in cardiology fairly routinely, and one of those is a stress test. It's very, very common in cardiology for someone who is of middle age to be asked to walk on a treadmill and put some stress on their heart, or if they can't do that, like perhaps if they have arthritis, we'll give them a medicine that replicates walking on a treadmill. Very, very common test. Not particularly expensive, and by that in medicine I mean probably less than $1,000. It depends on the exact circumstances, but generally less than $1,000. It's not a lot of money. I don't want to say that $1,000 isn't exorbitant, but it's, in the grand scheme of things, it's not $1 million ICU stay, it's not an open heart surgery, and it's a very useful test that gives us a lot of information about whether or not that patient very well might have something potentially fatal going on, or a setup for that, or if it's a false alarm. People get chest pain for lots of other reasons. They can have acid reflux or heartburn, they can have muscle pain, pain in between their ribs, inflammation around the lining of their lungs. Lots of things can give people chest pain. And so it's very, very common for a cardiologist to order a stress test in a middle-aged guy with chest pain. But just the other day, this happened in my office. I had a middle-aged guy come in. He had an abnormal electrocardiogram, which is a glaring sign that something is wrong. Gave me that exact story, saying he was having chest pain when he exerted himself. So I ordered a stress test. And a week later, the patient is back on my schedule. And I didn't hear anything about this, except I saw him back on my schedule, and we get our little blurb on our daily printout, and it says reason for visit, and the first thing on the visit said stress test denied. Now, I won't name the guilty party, the insurance company that denied this, but this is where waste gets created in healthcare. So now this guy, who should have been stress tested immediately, shows back up to my office. He's still having chest pain. He's still having symptoms. And I have this just generic canned, it looks like it was written by AI letter saying that, dear Dr. Raj, we've reviewed your medical record and we think that Bob doesn't need a stress test. If you would like to appeal this denial, dial this 1-800 number and press 7 and wait for 40 minutes and we'll have a peer-to-peer discussion with you. Like, I'm going to do this in the middle of my busy day seeing 20 other patients. And this is the only way to move forward, honestly. It's the only way that we can get this patient this test. And it's still a coin toss at that. Even if I say, all right, block out an hour on my schedule at 9 o'clock tomorrow morning, cancel the patient that was supposed to be there, and I'll sit on hold and wait for someone at this insurance company to facilitate this peer-to-peer, there's still a 50% chance that it's a very contentious exchange, and no matter what I tell them, no matter how I try to explain it to them, they will simply say, well, our guidelines say this isn't necessary, it isn't indicated, and they hang up the phone, and that's the end of it. And at that point, we have a real problem, because now I have a sick patient whose life could be hanging in the balance, and we have a very simple and easy test that could answer the question and tell us, do we either need to escalate this and do something much more serious, or can I give the patient reassurance and give him that peace of mind that we were talking about earlier, so he can go home and actually sleep for 8 hours that night and not wonder if he's going to die of a heart attack. And we have this dreaded peer-to-peer discussion put in the middle of it. It's a total imposition that is unnecessary. It absolutely has no business being there, especially for routine things in medicine that should be, totally left to the discretion of physicians and should never be decided by an insurance company. And yet it is routinely every day. And while that might sound frustrating to some people, what most people listening to this probably don't realize is that this is the routine. This happens multiple times every single day of the week. There isn't a day that goes by that we don't face multiple of these on a routine basis. And over time, this really, really adds up. The cumulative effect of just knowing that you're trying to do the right thing, and every time you try to do it, you have this impossible amount of red tape thrown up in front of you, and all you're trying to do is help someone. It becomes really, really difficult.
It's also a big part of what I do in my practice in primary care, because we're often ordering kind of the initial round of testing across a variety of different specialty areas, because we're sort of the jack of all trade, master of none kind of thing. And in cardiology, you mentioned there's a certain number of tests that you routinely order, and it's maybe a dozen. But for us, it may be hundreds of different kinds of tests. And then you multiply that across however many, say there's top 10 insurance companies that we work with, and they all have slightly different requirements in terms of what gets covered and what doesn't get covered and under what circumstances. You mentioned a word that stood out to me, which is guidelines. So what I don't even to this day fully understand is who sets the guidelines for the insurance companies in terms of what gets kicked over to a peer-to-peer, because we are very clear as physicians of what guidelines we're held accountable to. They're set by our specialty societies, and it's like if you don't follow the guidelines that are set by the organizations that regulate us as doctors, you're accountable for an adverse outcome if you did not follow the standard of care, so to speak. But these guidelines that are set by the insurance companies, do you have any knowledge as to how much overlap there is with what we would consider the standard of care and the guidelines that as doctors we are held accountable to?
Well, I think there's definitely a disconnect for sure. And so, as doctors, we do have guidelines to follow for sure. They're sort of like roadmaps or kind of documents that are published that we're all expected to read as physicians. Every specialty in medicine has at least one, often multiple societies that meet regularly and have thought leaders from that specialty come together and formulate best practices that are then disseminated to all of the other physicians in that specialty. There are usually annual meetings where these things are emphasized and taught. Oftentimes now there are webinars you can attend. Websites have updated guidelines. They're published in all the major medical journals. The big ones, JAMA, the New England Journal of Medicine, will cover the major groundbreaking changes that may impact guidelines. And these are what we are supposed to use as physicians. Now, again, well, like we talked about, there's the science and there's the art of medicine. Not everything can fit neatly within the confines of a boundary of a guideline, but most things can, or at least general concepts can be made pretty clear and easy to follow. The problem is that these insurance companies don't necessarily use those guidelines. And several of the more notorious companies that are, let's just say by reputation, known to frustrate doctors, use a third-party company. That company's name, I guess I will leave unnamed. You can Google it. It won't take you much effort to find it with a Google search. But this third-party company has drafted their own guidelines. I don't know where they got them from. I can tell you that they don't match particularly well with the guidelines that I've been taught. And oftentimes I will cite American College of Cardiology guidelines or American Heart Association guidelines or whatever particular society guidelines come into play for whatever test we're trying to order. And they will simply say, well, our guidelines don't reflect that particular policy or that particular protocol, and the test is denied. And that's the end of the discussion. And it's extremely painful because at that point, there really is nothing you can do other than potentially report them to the state insurance commissioner or something like that, which rarely will yield positive results. But again, even at the best possible outcome you could imagine under that pathway, will delay care for a long time. And oftentimes we don't have weeks to months to wait. You certainly would be unethical to let somebody with active chest pain go weeks to months before pursuing definitive testing to figure out whether or not they were going to have a heart attack or not. People could die while they're waiting for that result to come back.
I think about the case that you described and the fact that that stress test was denied and what the next step would be if I'm in that role of having to help this person navigate their health. And the only thing that comes to mind for me at that point is you have to send them to the hospital. You have to send them to the ER, kind of give them a script of what to say. I went to my cardiologist. I was having this issue. I was supposed to get a stress test. The insurance wouldn't cover it. I went on a walk with my dog today. It came back. I'd like to be evaluated. And I think about the fact that because of EMTALA, and people may not know what that is, but there are federal laws that require every person that shows up to an emergency department to receive an emergency medicine evaluation to assess for any life-threatening conditions, and that's regardless of ability to pay. And as an ER doc, I, in some ways, benefited from not having to deal with the frustration of what my colleagues in outpatient medicine have had to deal with, because I had the luxury of not having to really think about if something was going to be denied, because it didn't matter. At the end of the day, I'm required by law to provide care to whoever shows up at my doorstep in the ER. But a patient like that, that's having, I would call it unstable chest pain. I would even venture to say, if they have an abnormal EKG, which you mentioned earlier, and they happen to be having chest pain, that they have acute coronary syndrome, which would be an indication for potentially observation, lab work, and a cardiology workup in the hospital. That workup in the hospital ends up being so much more expensive and unnecessary expense, right? Because you could do the same thing in your office with a stress test that we would be doing. You mentioned that test in your office would be less than $1,000. We might be doing a $10,000 or more workup if that patient ends up going to the ER to get essentially the identical workup. And so in a way, it's completely insane that we have this scenario, because it's self-defeating. It's driving up the cost of care. It's creating frustration. Like you mentioned, it's causing waste. It's just hard to fathom how that can be happening in 2025.
Couldn't have said it better myself. That's precisely the problem. And self-defeating would be a great way to describe it. So that patient, my patient in the office that had chest pain, obviously, if I'm upholding my oath to do no harm, I cannot let multiple suns set on that gentleman's complaint without really trying to figure out if he's at risk for having a heart attack or not. Our one lifeboat is, as you referred to, EMTALA, the Emergency Medical Treatment Act, that essentially requires that emergency rooms take care of emergencies in this country. So for our listeners here, if you have a true medical emergency and you go to an emergency room, regardless of your ability to pay, whether you have the best insurance in the world or no insurance at all, that hospital is obligated to treat your emergency. There is no negotiating on that in the United States. It's one of the best parts of our healthcare system that's still intact today, in my opinion. But unfortunately, that becomes the lifeboat for all of these horrible abuses that are perpetrated against doctors and patients by the insurance industry now, which is when reasonable doctors order reasonable tests on patients with reasonable complaints and their care is denied. And so that is exactly what would happen. I would tell a patient, look, if you're having chest pain and it's not getting better and I can't test you if you keep having chest pain, the next step here is to go to the emergency room. If your chest pain comes back, we don't have a choice. And that creates this absolutely ludicrous scenario where I have all of the equipment. I have the treadmill, I have the imaging camera in my office. It's basically the identical camera to what we have sitting in the hospital, just steps away from that office. And my camera could be sitting empty all day. I have all the time in the world, and I could do that test for about $1,000. But instead, the patient has to go to the emergency room. They have to go see the triage nurse. Then they have to be seen by an emergency physician before they can even get the diagnostic test ordered. And what does that do? Well, if you're the guy that's got a potential appendicitis sitting in the waiting room holding your lower abdomen in pain, you're going to have to wait until the heart attack gets seen first, because that's going to take priority, the potential heart attack, I should say. And it gums up the works. It creates this unnecessary logjam in our system, and patients suffer more than anything from this. And the truth is, we could do a stress test in an outpatient setting. Many other doctors can do things in the outpatient setting that don't need to be done in the emergency room. But because we can't just abandon our patients when their insurance company says no and they tie our hands, the emergency rooms become that last resort, and it really is a problem.
Or, for example, we can't get our patients in to be seen in a timely manner because we're doing peer-to-peers or we're doing other administrative tasks that really serve no purpose.
Absolutely. Couldn't agree more. One of the things that we are now really required to do in order to get paid for what we do, for the most part, is we have to document the amount of time that we spend for what we call global encounter caring for the patient. And that includes actually seeing the patient, counseling them on whatever problem that they need counseled on, coordinating their care, including all necessary follow-ups, and then actually documenting every single thing that happened during that encounter in their permanent medical record. The documentation part and the coordinating care part is the part that most patients do not get to see. I think there's this sort of happy-go-lucky idea that you walk in, you see your doctor for 5 minutes, the doctor says, oh, we're going to prescribe you X, Y, or Z, you go to your pharmacy, you pick it up, and it's a very simple transaction. And the reality is that there's a lot more complexity to it. For every 5 minutes that a doctor spends with a patient, there's easily double that spent on care coordination and documentation. Most doctors, just in order to get through our day, we actually defer writing all of those notes, completing all of this paperwork, filling out all of these prior authorization requests, dealing with portal messages and all of these things that are not reimbursed and don't help us keep our doors open with revenue. And I know some doctors, some of them are my partners. I hope they're not listening to this podcast, but they will literally spend hours upon hours after our doors close at 5 o'clock. One of my partners is notorious for being there 9, 10 o'clock at night, still writing notes every single night, and then coming in on weekends on his day off to finish writing notes. And patients just don't see that. And that was not always the case when we talked about things earlier in our discussion today about things that have changed. We didn't have to do all of this before. We didn't have to have 18 bullet points and all of these little things that are audited, for compliance because some regulatory agency says we have to check this box or do that thing in order to get paid this amount of money. And that's changed. And unfortunately, that's just something that, one person, one physician, one solo practice doctor cannot stop. It's like trying to stop a locomotive. By standing in front of it, you can't do it. You'll get run over. There's a lot more that goes on behind the scenes than just those minutes that you spend face to face. Hopefully it's a lot of minutes. Unfortunately, I think the encounter times are getting shorter and shorter as the years go on because we have to see more and more patients to make ends meet, and we have to spend more and more time clicking boxes and documenting things that previously didn't need to be documented. But that's an area, sort of the man behind the curtain, right? It's like the Wizard of Oz that most patients just don't really get to see or appreciate, and it's not a good one. I would not label that as one of my favorite tasks as a physician.
I think that's an understatement. I think also from my standpoint, because I am the CEO of our practice and I work on the business side as well as on the patient care side, and I work directly with our billing team, one of the things that I see that I never saw when I was working in the hospital is all of the denied claims. So what happens is you submit a claim. After you see the patient, you submit the claim to the insurance, and then you pray that you get paid. And sometimes you get paid, but sometimes you don't get paid. And when you don't get paid, they usually request records to justify with the documentation the level of complexity of the visit. And if those boxes aren't checked, if all of those details that you were just describing are not included in the chart note in the way that the insurance company wants to see them, for them to sign off on, yes, this meets our standard of complexity for this level of reimbursement, then you just don't get compensated for that care. I'm not really sure if my mentors of the past that are now long retired had to deal with that kind of thing on the same level. I don't think they did.
Certainly they didn't. And I think medicine, like anything else, has become a bureaucracy. There are people that have been entrenched in it. We used to have a few requirements and then we added a few more. And now it's justified, I think, by the non-physician overseers that tell us what to do, that you have to click this box or put this statement in if you want to have this level of complexity or use this code. This is all things that shouldn't make sense to our patients, and for right reason. It doesn't make sense to us either. But yet this is the reality that dictates whether we get paid or not. And I think it's very, very frustrating to work very hard and to want the best for your patients and do all the right things. And then, after giving a half an hour or an hour and a half, 2 hours of your time, to not get paid for it because you didn't click some box or document that you told someone to lose weight or remind them to take their aspirin, which they're already taking. It's very, very frustrating. If I had to look at the changes that have happened in medicine, and I think again about the overall topic here of your podcast, your doctor wants to quit. Why do doctors want to quit? Well, my answer to that question is doctors want to quit because of this term that has been put out there called moral injury. This idea that we want to do what's best for our patients. We want to do the right thing. And yet there are all of these external forces that we are governed by that prevent that from happening. The antidote to all of this, in my opinion, is that doctors have given up control of medicine. We have lost our authority as the figures who decide what is or isn't right for our patients. We have put ourselves second or third or even fourth in command for making decisions that impact our patients' lives. And I think my message to my physician colleagues is think very hard about everything you do, the choices that you make, the people that you choose to work for, the amount of resistance that you do or don't put up against some of these horrible ideas that are being thrust on us now as physicians. Once upon a time, doctors owned their own practices. Private practice thrived across this country. If you went to see your doctor, that meant that your doctor owned that business. He was in charge. He decided what time to open the doors, what time to close them, how many employees to hire, what medicine you needed, what medicine you didn't, what kind of bandages to use. All of these things were decided by that person, that physician. And so much of that has been eroded and stripped away as we've entered into this era of vertical alignment. That's a very important term I think we need to define, which is that as reimbursement has declined for physicians over the years in this country, the only way that medicine and doctors have been able to counteract that is to form bigger and bigger and bigger alliances, bigger companies that can try to push back against these reimbursement cuts and rising expenses and inflation by economies of scale. But somewhere in that process, non-physicians started to insert themselves, and they became a bigger and bigger and bigger piece of that equation. And now in 2025, we have physicians largely just working as employees. They punch a card, they work a shift, they go home, they do what they're told. And we don't have choices. We're told, well, you can only use this catheter, or you can only use this guide wire in the cath lab. You can only use this particular blood thinning medication. You can't use this one because it's too expensive, or we've decided that our formulary committee doesn't think it's cost efficient in our organization. And doctors have nothing to do with any of this. And, we've had changes, we've seen changes up and down throughout medicine, whether we're consolidating things or eliminating choices or eliminating options or going with cheaper medicines. And these things are just dictated to us from up on high. We don't have choices. No one asked my opinion about whether or not we should drop this catheter or not use this medicine from our menu of options. It just sort of happens. And it's part of the bureaucracy. It's part of this change that has happened as a result of reimbursement changes. And there's very, very little differentiation now between large hospital systems, who are also now allowed to sell insurance products, and they're also allowed to employ physicians. And so now you have hospitals who employ physicians who also sell insurance products. And that's really, in my opinion, a rather large conflict of interest, but yet it's allowed to happen, and it happens every day, and it's the norm now in this country. Whereas before, it was more like checks and balances, right? There was an insurance company, there was a doctor, there was a hospital. These entities weren't connected. But now that they're all sort of one giant conglomerate, one big mega corporation, there's not a lot of choice, and physicians have very little voice in these very large organizations in determining what's best for patients. So I would say to my physician colleagues, think very long and hard about who you align yourself with. And if you're a doctor, if you're a resident particularly, and you're listening to this podcast, particularly if you're listening to us today, any chance that you have to stay independent, to stay private, to put yourself in a position with more autonomy, where you're not an employee, where you don't have to do what you're told, where you can think independently and you can make choices, even if that means learning a little bit about business, I think that's a great opportunity to consider. Don't underestimate yourself, future physicians, if you're listening to this. Business isn't that hard. It's not that hard to grasp. It's a fairly simple concept. I actually went to business school myself and got an MBA. If you're motivated, anyone can do it. It's certainly easier than medical school, that's for sure.
It almost feels like the system is rigged against new graduates to make it less desirable to start their own practice, because now you finish with so much medical school debt and you've been beaten down through just the rigors of training. It's such a long journey, so many years of not making really any money at all and being very poor, and spending a decade of your life in service of others and in training, and not generating savings towards retirement or any of those things that we need to have a healthy life as we become more mature adults. And so you're starting the beginning of your career essentially in your 30s, whereas most people would start in their 20s. And then you look at the cost of capital, taking out a loan to start a business, and what that would mean, the likelihood of being able to generate revenue because you're not sure if you're going to even get people coming into your practice because you're not necessarily connected to a large health system that's going to feed referrals into your practice. And so that in itself is taking a risk. And you look at all of that, meanwhile, someone is dangling this paycheck in front of you, and that someone is a healthcare system, and says to you, just show up and clock in and clock out, and you're going to make X, and all of your problems are going to be solved. It's very tempting to take that path of least resistance.
So now you have $400,000, or maybe if you're lucky, $200,000 or $300,000 of student loan debt. And the truth is, when you start your training as a resident, you don't make the kind of money that can even make those payments. And so most people that aren't very lucky to be independently wealthy opt for what they call forbearance, which basically says, look, I'll pay you someday, but I can't pay you now. And the bank says, great, but we're going to add interest. It's like if you don't pay your credit card payment, right? You charge $100 on your credit card and you have this very high interest rate, and you don't have that $100 at the end of the month, so you don't pay it. And then the next month, now you've got $117 on that credit card. That's how forbearance essentially works with student loan debt. And most of us have to forbear that debt for 2 years, 3 years, 6 years, some people even longer, depending on how subspecialized you become. And you wind up with this absolutely insane snowball of debt at the end of it. And so that's just the training part. So put that aside for 1 second, and now let's just pivot to the business side of it. When you're starting as a new graduate, your income is basically zero because you've been making pretty minimal money for the preceding year. It's close to nothing. And your debt is enough to buy a small jet. And your debt to income ratio thus is about as horrible as anyone could possibly make it look. And so how would you possibly get a small business loan to hang your own shingle and open your practice? The answer is it doesn't happen anymore. And that is the tragedy of the situation that we currently find ourselves in, is that I think the solution in a practical sense is for more doctors to become independent, to unite with each other, and for doctors to take control of medicine again, and not others who aren't physicians. You shouldn't have someone who isn't a physician making the decisions as to whether or not you get your CAT scan or your cancer treatment or your stress test. But that is the norm now. But it's very hard to even chart out a path for us to take this back, because until physicians can have autonomy and independence, it's hard to even conceive of a scenario where we can put ourselves in these better positions anymore. And I think that's, again, what is leading people to run for the doors. Your doctor wants to quit. That's why they want to quit. There is no good option other than to look at that bill that comes in your mailbox that says you've got to pay us or the interest is going to go up. And then you see this shiny offer from a private equity owned practice or a large for-profit healthcare system that's going to offer you a salary, and you don't have much choice. I don't fault the people who take these jobs for taking them, but unfortunately, the more people that do, the more power physicians lose to try and impact change for the better. And I think that's really what is souring a lot of the mood in medicine right now, is that we are not at a high point where physicians have a lot of control or a lot of autonomy or even a lot of impact on the decisions that get made that impact patient care. I actually teach medical students. And I would say if one thing has probably kept me going, it's that, because I still see these young third and fourth year medical students come into my office, and they haven't necessarily seen some of this ugliness that we've talked about here today. And I see that true passion in their eyes and that desire to push themselves harder, to go home and learn more and read more and be better the next day for their patients, and to go that extra mile. And when you see that spirit, you realize that no matter how much things change, some things are just truly universal and stay the same. And I do believe that no matter how many obstacles are put up in front of us that are trying to really get in the way of good patient care, that there are still really, really good people in this country. Some of them come from a legacy of physicians, and some of them are like me, the first physician in their family, that no matter who they are, get up every day and they want to do their best so that they can provide the best care to their patients. And when I see that spirit that's just so undaunted and still so pure and unspoiled, it inspires me to keep going, and it inspires me to do things like this, to have conversations with other doctors that have a vested interest in us trying to take this profession back from the people that took it away from us. I think some people, unfortunately, for their own mental health and well-being, they do need to hit the pause button and walk away. Some people, unfortunately, do need to quit. But I think what inspires me to keep going, and the reason that I haven't quit, and the reason that for the time being I have no intention of quitting, is that I think that this is a fixable problem. It's a huge problem. Don't make any mistake about it. But there are a lot of us that are still invested in this, that believe that we can change this. But one thing is for sure, we can't do it ourselves. And the biggest allies and the biggest advocates we need to impact this change are our patients. We cannot do it alone. Doctors by themselves are not loud enough and strong enough. We need patients to stand with us, to stand alongside of us, to write your congressman, write your senator, talk to the other people in your community that have interest in this and say, look, this is not the way it should be. Speak up, speak out. When your test gets denied, call your legislature, send that denial letter to your congressman or to your senator, appeal that denial to the insurance commissioner in your state, send it to the consumer protection bureaus, speak out. If all of us take an interest in this problem and start taking active steps to impact this change, I think that we actually can bring medicine back to what it used to be, which was a pure interaction between a doctor and a patient.
Thank you for listening to Your Doctor Wants to Quit. I'm Dr. Joy, a board-certified emergency physician, and I created this podcast because I'm on a quest to fix healthcare in America through conversation. If you liked what you heard today, please follow this podcast or find me on Instagram at Dr. Joy MD. That's DOCTOR Joy MD.